today's webinar titled Policies, Training, and Systems to Protect the Integrity of the Medical Record. As an introduction, although clinical documentation plays a central role in electronic health records, as the EHR, and occupies a substantial portion of the physician's time, documentation practices have largely been dictated by legal and legal requirements. We've seen over the years that when it comes to clinical documentation, a lot is expected from the physician as to what meets the billing and legal requirements. Yet the primary role of documentation should be to clearly describe and communicate what's going on with the patient. That is the underlying value of clinical documentation, because when the physicians and other providers document in the medical record and the documentation is clear, communication flows seamlessly across all providers and the continuum of care. Talking about the next point, the purpose of complete and accurate patient record documentation is to foster quality and continuity of care. It creates a means of communication between providers and members about health status, preventive health services, treatment planning, and delivery of care. I'll pause to talk more about this as well. Everything boils down pretty much to the quality of care given. And when you have good documentation, clear, concise, precise documentation, it fosters quality of care given to the patient. And members or patients can easily access the medical records and see what's going on with them as well. A fundamental question is how best to utilize the electronic medical records to enhance clinicians' workflow, provide accurate quality of care, and ensure that the integrity of the medical record stands. So the bottom line is that we want to ensure that our records are accurate and they can stand the test of time, meaning anywhere you bring it up, it stands on its own. So talking about the electronic medical record, what is it and how do we utilize it? The advent of the electronic medical record has been both a blessing and a challenge, and we can all agree that there's a lot of value that comes with using the electronic medical record. It's just that it has some challenges, but those challenges are not without ways to mitigate them. So it has been both a blessing and a challenge, with all users experiencing simultaneous improvements and decrements in efficiency. Despite being packed with data, medical record documentation is increasingly devoid of information, which places patient care and regulatory and billing compliance at risk. While it has everything that we need or that would help facilitate documentation, we've seen that sometimes it's devoid of information that is critical to that patient's care. High-performing healthcare systems increasingly are recognizing these risks and are taking measures to effectively improve medical record integrity. So the challenges is what we have been able to identify, or various systems have been able to identify, because it's devoid of information and there are certain things that you don't need there to meet certain regulations but are not there. So organizations are taking steps to mitigate the risk involved with that. Focusing on an individual behavior, user behavior will help identify the common risk point areas. And how to measure this risk is also necessary, and it also provides an insight on how to remediate the situation. We'll continue talking about the electronic documentation, and documentation in the health record has evolved over the years from being completely on paper. And we know what that was like, having all paper documentation where you have either papers missing or you can't read the physician's writing, or things are misinterpreted, of course, due to illegible writing. So now we have either a fully electronic system in some health systems or a hybrid system where paper is still being used in combination with the electronic health records. Of healthcare provided is greatly influenced by the ability of providers to have access to complete and comprehensive health information of patients. This cannot be overstated. If our providers have access to a complete and comprehensive health information of patients, they're able to diagnose and provide the right treatment for their patients and also able to monitor their patients. Electronic documentation eliminates the problem that comes with illegible documentation. We spoke briefly about that as well. Thus, improving the accuracy of patient information. This cannot, like I said before, overstated. It's all about patient care and patient safety. So documentation doesn't just go to, okay, we are able to treat our patients right, but also it has to do with the patient safety. Electronic documentation fosters better communication between providers. It also provides the benefits of timely and accurate communication. And this, of course, cannot be overstated as it improves quality of care provided. So when you document electronically with, in this present day, where you document and it goes to the other person in real time, it's crucial to have this form of documentation. What are the features of an EMR? Electronic documentation tools offer many features that are designed to increase both the quality and the utility of clinical documentation, enhancing communication between all healthcare providers. These features address traditional, well-known requirements for documentation principles while supporting expansive new technologies. The use of these features without appropriate management and guidelines, however, may create information integrity concerns such as invalid auto-population of data. And we see this a lot with when we have templates or when physicians copy and paste. Okay, and the manufactured documentation, sometimes when it auto-populates, it's sort of aimed to increase expected or enhanced reimbursement, but sometimes the documentation is not valid for that episode of care. So that's one area that needs to be looked into. Processes must be in place to ensure the documentation for the health information used in care, research, and health management is accurate, complete, trustworthy, and timely. So while we are utilizing the various tools that EMR provides, we want to be careful to use them appropriately so that we can have a valid, accurate, complete, and trustworthy documentation. So talking about the integrity of the medical record, documentation integrity involves accuracy of the complete health record. It encompasses information governance, patient identification, authorship validation, amendments, and record corrections, as well as auditing the record for documentation validity when submitting reimbursement claims. This is very important because when your documentation has integrity, it can pass any, for lack of a better term, it can pass through the fire and stand the test of time. So it's important to have auditing because you can easily go back and see where you had problems and make corrections or amendments as needed and as within guidelines, of course, and policies. EMRs can be customized with the templates, smart phrases, and smart links to assist with documentation. This makes the lives of the physicians easier. Although we have providers that are still hesitant with technology, utilizing new technologies, but it goes a long way when they have templates or smart phrases and smart links. It speeds up their consulting time and they're able to document what's needed for that patient. But poor utilization of these tools to assist documentation can lead to questioning the integrity of the medical record. So yes, while we have all these wonderful tools that can help us document, speed up the process of writing notes and all, if they are not utilized properly or they're used for the wrong reasons, it puts in question the integrity of the medical record. Still addressing the integrity of the medical record, Established policies and procedures such as audit functions must be in place to ensure compliant billing. And billing, it depends on the documentation. If the documentation is wrong, everything else falls apart. And without safeguards in place, records could reflect an inaccurate picture of the patient's condition, either at admission or as it changes over time. The provider must understand that the necessity of reviewing and editing all defaulted data to ensure that only patient-specific data for that visit is recorded. And that goes to validation of the documentation, especially when it also populates. And while all other irrelevant data pulled in by the default template is removed, pretty much when they're reviewing their data, they want to make sure that they remove every irrelevant data. For example, the automatic generation of common negative findings within a review of systems for each body or organ system may result in higher level of service delivered. And unless the provider documents any pertinent positive results and deletes the incorrect auto-generated entries, there will be problems. So you want to make sure, the providers, you want to make sure that they understand that while they have templates that have all the systems and all the things they have to check off, that they go back and remove the negative or irrelevant ones so they have a better picture of the patient. So how do we continue to ensure the integrity of the medical record? Providers must importantly recognize that each encounter is a standalone record. Each episode of care stands on its own, and he or she has to ensure that the documentation of that encounter reflects the level of service actually provided and meets payer requirements for appropriate reimbursement. The integrity of this information is very vital, and as was noted in a testimony by Michelle Doherty, if the documentation is inaccurate, then it was wrong to be used for anything at all. So it goes down to the foundation, which is the integrity of the documentation. If it's wrong at the base, then it has a rippling effect. Every other thing becomes wrong. Information governance. We talked about this as part of one of the tools of maintaining integrity of a record. Healthcare organizations must manage information as an asset and adopt proactive decision-making and oversight through information asset management, information governance, and enterprise information management to achieve data trustworthiness. AHIMA defines information governance as the accountability framework and decision rights to achieve enterprise information management. EIM is also defined as the infrastructure and processes that ensure information is trustworthy and actionable. An accurate information governance program will ensure the accountability of how information is managed and the information's integrity. It all boils down to integrity of the information given on the medical record. All the checks and balances put in place to ensure that we have accurate information that is derived from the patient record. So with the EMLs comes some challenges as well. And the main challenge is when documentation practices become risky. And that can be seen in where there's an auto-population without removing irrelevant data. Risky documentation practices that create the potential for patient safety, quality of care concerns, such as those we'll be describing in the next slides, may leave an organization vulnerable to patient safety errors and medical liability. We cannot overstate the fact that medical the documentation in a medical record has to be truly reflective and accurate of the patient's severity of illness and level of care provided. What are the templates? I'm talking about the template documentation challenges. Documentation templates can play an important role in improving the efficiency of data collection, ensuring that all relevant elements are collected in a structured format. However, these templates also have limitations. So while this tool is a great tool to have a template, either generic or specific, because it helps in data collection, because there are certain things our providers can miss out that is crucial when we need data collected for various purposes, including research. So these templates sort of fit the bill and help guide documentations in a way, but it does come with some challenges. So there's some times you might have templates that do not exist for a specific problem or visit type. And it can occur if the structure of the note is not a good clinical fit and does not accurately reflect the patient's condition and services. So sometimes you do have that where you do not have the specific template that the unique visits that you have in front of you. Sometimes you have atypical patients, and we have patients that have multiple comorbidities or that require extensive interventions, and sometimes they are limited as what they can put into these already set out templates. So sometimes they can't go beyond a certain number of diagnoses, or they cannot go beyond a certain number of procedures. So that poses a challenge for the provider. Templates designed to meet reimbursement criteria may miss relevant clinical information. So when it's tailored mainly to make sure that the physician imputes all the services just for reimbursement purposes, they might miss the opportunity, or the physician might not be able to document all the relevant clinical information that the patient presents with. Templates may also encourage over-documentation, and that's another problem we can have, because you are overly documenting even things that are not relevant to this encounter, just because you have to meet certain reimbursement requirements. When services are not medically necessary or never delivered, this can happen where the physician has to check some boxes and all, but these are not, it's also time wasting in a way. Another problem we have is the cloning, copy, paste practice problems. You would all agree with me, CDSs, coders, all those in the HIM field pretty much have experienced this problem one time or the other, where our providers clone or copy and paste their documentation. For as long as medical records have existed, physicians have been copying information from prior visits, and rightly so, because sometimes they need to follow up on what they have previously documented in a previous encounter, or kind of compare notes for the patient's status, health status now and in the previous encounter, or to guide them in therapy. So rightly so, sometimes they need to go back to previous encounters. Where the problem lies is that when they do this, they do not validate or make sure they take out irrelevant data and blindly copy and paste. So that's where we have an issue where copying and pasting is done blindly. So whether this was done in a paper chart by reading and rewriting content from other written notes, or by dictating directly from a prior transcription, documenting providers have routinely used older information to create new notes for patients. A patient's care information must be verified individually to ensure accuracy. It cannot be cut and pasted from a different record of the patient, which risks medical records as well as overpayments. This is very crucial, because sometimes being in a hurry or just not paying attention, physicians have been, in one way or the other, can copy and paste from a different medical record of a different patient into another patient. I know I've seen that before. Or sometimes they copy and paste a lab value from a previous encounter and bring it to the new encounter, and we know how dangerous that can be. So it's crucial that in copying and pasting, data is validated. Still talking about the copy and paste, allowing physicians to copy and paste data and sections from prior documentation can help them create more complete documentation and notes quickly. So it speeds up their documenting time. but at the same time, they want to be careful. Ideally, this practice should result in time savings for the physicians and more complete patient information capture for communication with other providers, as well as for use in reporting, coding, and billing purposes. This, of course, we know is in a perfect or an ideal world where everything it works as it should, but we know it doesn't when we come to practicality of it all. So that's why we want to make sure that when we are talking with our physicians, that they understand the gravity of not validating or going through what they're copying and pasting before signing off on it. Of the EHR. We're going to be talking about the appropriate use of the EHR. The HIMA position paper titled Appropriate Use of the Copy and Paste Functionality in an Electronic Health Record outlines the risks and challenges associated with the use of copy and paste in the EHR. And they include, they're not limited to this, but they include inaccurate or outdated information when they don't update the information they're pasting. It's just like with a problem list, when they keep on populating without updating the problem list. Redundant information, which makes it difficult to identify the current information. I personally have encountered this where it's just brought forward. All the information is brought forward and you're trying to sift through to see which one, okay, what in this information pertains to this admission, seeing that it's just bringing forward all the other documentation. Inability to identify the author or intent of the documentation. This especially, the here is especially when you have various providers. Let's say you have the MPs, you have the PAs, you have the residents that are also seeing the patient, and you are trying to decipher, especially when you're sending or the physician assigned to the case is supposed to co-sign. So sometimes you're trying to, okay, who authored this? What is he co-signing to? Because once he co-signs, he's taking responsibility of that documentation. So inability to identify when the document was first created. And we do see this because sometimes our physicians, because of the time, they don't have enough time. Sometimes the patient is admitted to the he creates his HMP tomorrow. And you're trying to say, okay, when was it first created? Was it on the day of admission or the day after or 2 days after? Propagation of false information. While this might not be intentional, what happens is that when a physician is bringing forward documentation, why it becomes false is because it's not relevant to this current admission. Internally inconsistent progress notes. Yes, sometimes we do see this, and this is like the big headache for all CDI specialists. When one physician is saying something, the other is saying something else, and you have, and that becomes either they're copying and pasting, or choosing wrong templates, or using wrong smart links or smart phrases, and you have inconsistency. And we have unnecessarily lengthy progress notes. I've seen progress notes 50 pages wide, I'm talking about the EMR, like 50 pages long, and it's not, you can't really find what they're talking about because they're just bringing forth information or using templates that, do not necessarily address the problem at hand. So talking about examples of copy and paste and the risks involved in it, our first example is about it's going to border on patient care safety issues and avoidable costs. The scenario we have in front of us, that of a 62-year-old woman with CHF admitted, the hospitalist on the morning shift ordered some tests and the potassium was 5.1. Every other chemistry was normal. The BMP was elevated, of course, because she has CHF. And while creating his HMP, he brings forward notes from a prior admission in the prior year. And on that admission, the problem was that the potassium was at 2.9, which is hypokalemia. Based on that lab, without him validating that number, he orders potassium for the patient and also recheck of her potassium level the next day. The consequence of that all is that, first of all, this patient does not have hypokalemia. And you're giving her potassium, and which can have devastating effects on the patient. Ordering a recheck also is an added cost to the patient, the cost of taking care of that patient. So not only have you put the patient at risk, you're also incurring costs for caring for that patient. Another example, not on the slide, is, for instance, we have a 76-year-old male who has been admitted. He has hypertension, diabetes, UTI, and this is history of, and of course, history of the UTI, I would like to add. At the time of discharge, the physician brings forth the notes from previous admissions, and he has pneumonia, hypertension, diabetes, and UTI. Why I'm stressing that UTI is because when that is coded, the simple pneumonia pleurisy with and DRG will become the DRG 194, which is simple pneumonia and pleurisy with a CC. So the reimbursement, of course, will be based on the fact that the patient has a comorbid condition that increases the weight of the DRG. So the problem with this is that the patient never had UTI on this admission. It was based on a prior admission. And he has brought forth that documentation without validating that diagnosis. And the consequence is that the hospital was overpaid based on the fact that that DRG is the DRG with a CC. So that is another case where we could have such a problem where physicians need to be mindful of the documentation. They need to pay particular attention to what they're bringing forward. We know copying and pasting can help increase the speed in documentation, but we can't emphasize how crucial it is for them to go over the documentation they're bringing forward, remove irrelevant documentation, and then, keep the rest that is needed for this episode of care. Another example we have is where we have a physician documenting based on a family medical history, giving the patient a diagnosis, of course, unknowingly, without properly looking at what he was copying and pasting. So during an office visit, we have a physician creating a note on a female patient, copied history of breast cancer from the family medical history section of the note from a prior visit into this note, the note for this visit. He put it into the patient's current note as past medical history as opposed to family medical history. And we know that there's a huge difference between family medical history and past medical history. This information was then submitted to the insurance company, who noticed this new diagnosis, because if she's had past medical history of breast cancer, it affects her care, and of course the insurance issues that go with that as well. So the insurance company was going to cancel her coverage because they thought she might have misrepresented her medical history in signing up for the coverage. And that is big. And this would have cost the patient her insurance. And you can tell the rippling effect that comes from this. So what they did was they had to work for months to get that cleared up with the insurance company so that her coverage would not be dropped. They had to go to find all the records, got it copied and pasted incorrectly into, and bottom line is that they were able to exonerate her, for lack of a better term, they were able to get her to keep her insurance by showing that it was a mistake on the provider's part, bringing forward family medical history as her own past medical history. The thing is that with copying and pasting, it's while it helps physicians become efficient, like I said before, it comes with its downsides and the risk. We don't encourage or train our physicians to be able to pay attention. So what can we do? We can't take away copying and pasting because that's going to be too drastic, and there's going to be a major pushback. Our goal is to be able to identify the physicians that are having issues with copying and pasting and not paying attention to what they're doing, notify them, and educate them as much as possible. We'll talk about how to mitigate the risk down the line, but I just wanted to bring this up here because this came up, and we know this is real when it affects our patients' care. It affects their access to health care, as with the case of this woman, if she had lost her insurance. And we could see the gravity of having documentation brought forward without being looked at properly before it's authenticated. Because once it's brought into this admission or this encounter, it becomes like part of the encounter. So that is, those are some of the examples we have of the problems that could result from inappropriately copying and pasting documentation from previous encounter into the current encounter. How do we mitigate the risk associated with copying and pasting? Organizations must develop policies designed to address inappropriate use of these tools to minimize non-compliance. Common documentation risks that can result from cloning features include vital signs that never change from visit to visit, information copied and pasted from a different patient record. So that's the major downside. When a patient is coming and documentation that is used for him is being copied and pasted from another patient. Documentation from another provider, including the attestation statement. So this is when we see this a lot. The copy and paste and also copying the attestation. And that's a big issue. Identical verbiage used repeatedly for all patients seen by a provider. This is one way we can identify where there's a copy and paste. And we do see this a lot. They have little or no modification. They use, so for instance, it might be a female and there is a he or the patient is in pain when there's no pain. So providers must recognize that every patient is unique and must ensure that all health services provided is documented distinctively from all others. Still talking about the mitigating the risk associated with copying and pasting, we could also look at the kind of settings and tools that our EHR provides to us. If it's able to limit the type of content that can be copied from one record to the other, that would go a long way to help in mitigating the risk associated with copying and pasting. If we're able also to set the EHR to auto-populate lab results, test results, and vitals from the most recent versions of this EHR, of this encounter into the current documentation, instead of having the physicians physically going and copying and pasting, it will go a long way in helping out to reduce the risk associated with copying and pasting without validation. So it is very crucial that we have tools in place in our EHR, since this is what the physicians use to document, that would help them to avoid these errors. So another way is that if we can have text analysis, there are some EHRs that provide text analysis and is able to identify copy and paste errors, notify providers in real time, and when they see these errors, they're able to quickly correct the errors before authenticating that documentation, or that their documentation going to other providers, because sometimes when the physician's placed an order and he hits on a save button or a submit button, it goes to the nurses, it goes to the pharmacist, it goes to all other people involved in the care of that patient. So if you're able to have something in real time, like a text analysis where it scans through the physician's documentation as he's documenting it and alerts the physician, hey, there's a problem here, the physician is able to make the correction in real time before it gets transmitted across the board. Still talking about mitigating the risk of errors that comes with inappropriate use of the tools that help in better documentation. Organizations should have in place a process to ensure that providers are able to review, edit, and approve dictated information in a timely manner. So it's more like a spell check kind of a thing. Well, that's putting it in simple terms. But there should be a process where physicians are able to review what they have brought forward or documented, edit it, and approve dictated information. And this, of course, should be done in a timely manner. Since these documents are often used and exchanged, the importance of accurate and quality documentation in the EHR systems is critical. Everything boils down to how valid the physician's documentation is. Documentation integrity is at risk when wrong information is documented on the wrong patient record. Of course, this is not the only time, but this is more so a high risk. Errors in patient identification can affect clinical decision making. You can imagine when you have one patient probably with pneumonia, the other with just chest pain, and you're giving antibiotics to one and giving maybe nitroglycerin to the other patient that doesn't need it, and you're giving antibiotics to the one with chest pain. So that it involves, it can affect clinical decision making, affect patient safety, and impact the patient's privacy and security, because now they can have access to the other person's health information. And this can also result in duplicate testing, increased cost to the patients, providers, and payers. Patient identification errors can grow exponentially within the EMR if it's not caught immediately. So you can imagine if a physician documents another patient's note with another patient's information, it just goes down. It has a rippling effect. Except someone quickly detects that, or there are tools in place to quickly trigger that something is wrong here, that goes on, and then we have rippling effects. We're talking about mitigating the risk. The failure of organizations to employ front-end solutions that includes measures like sophisticated matching algorithms or other methods such as the use of biometrics, photography, or fingerprinting can put the organizations at risk. It's really important to have checks in place that can help prevent the misuse of the various we have in the EHR. Organizations must have a patient identity integrity program that includes performance improvement measurements that can monitor the percentage of error rates and duplicate records within its electronic master patient index. Policies and procedures must ensure that the key demographic data are accurate and used to link records within and across systems. So that can also play a role in preventing documenting another patient's information in another patient, because if we are able to link, once you scan in the right patient's ID, you're able to link the patient's documentation behind automatically. That way it helps mitigate the risk of putting another patient's information in another patient's record. Policies must address the initial point of capture as a key front-end verification. So it's important it starts from the beginning. If we're able to rightly identify the patient, we can have system in place that can help to check when information crosses over from one patient's record that is not supposed to another patient's record, and that can help prevent the risk of documenting wrongly in another patient's record. As outlined in the AHIMA toolkit, which is the amendment in electronic health record, addendums, corrections, deletions, and all patient amendments should be included in the record as identified and defined by HIPAA. In order to support the integrity of the health record, the EHR system needs to allow providers to make amendments. Yeah, we know sometimes physicians document, but they come back and say, hey, I missed this, and they're able to make amendments. And they want to say, have to have the ability to track corrections and then identify when an original entry has been changed. The functionality to do this can be a combination of EHR applications along with policies and procedures that outline when changes need to be made, what changes can be made, and who can make these changes, and how these changes can be tracked and monitored. The original entry must be viewable along with a date and timestamp. The date and timestamp is very important because we know sometimes the care of a patient changes and they have to update their medication. So we really need the date and timestamp, the name of the person making the change, and the reason for the change. This helps in the continuum of care. Without this information, the date sequence may be impossible to follow, adversely affecting appropriate care of the patient and resulting in questionable supporting documentation for reported services. So audits, what about audits? Everybody has encountered audits one point in time or the other. They're essential to ensuring that the health record documentation present supports the level of care provided, care or service, that all peer requirements for reimbursement are met, and that only authorized users are accessing or making entries to the patient record. This, with an audit trail, you are able to see what's going on with that account, who made a change, when the change was made, and the rest. Audit trails must include the name of the user, the application triggering the audit, the workstation, the specific document, a description of the event that is being audited. Is it an amendment, a correction, or a deletion? The date and time, very important. The audit trail must capture what is amended, including the deletions within the health record, and provide auditors with a starting point for compliance audits. Organizations may utilize the audit trail functionality of the EHR system to identify the trend utilization of health records. This functionality typically allows users to generate reports for specified time frame by the provider or by provider type, and results is sent directly to the compliance committee. Most organizations have a compliance department who runs audit trails for them. There are certain recommendations that can help in maintaining integrity of the medical records, and this includes education. We all know that education and training is really vital to the success of any EHR being implemented in any health system or organization. Organizations may need to devote more strategy to ensure that providers are well informed about the compliance and legal risks involved in misusing, underutilizing, or overutilizing their tools for documentation. This starts in the EHR training process. So it's very important that if we're introducing a new EMR or EHR system for documenting, that providers and all end users are well trained on how to utilize the tool and how to troubleshoot or escalate if they encounter a problem. Initiatives need to be developed in EHR education to make sure that every compliance risk is addressed and that people understand what is wrong and what is right in utilizing the tool. Staff education on best practices for documentation should focus on integrity of the medical record or the health record. So it's very important that when this education is carried out, there should be emphasis, because the bottom line is that we want to make sure that the documentation we have, it has its integrity. So it means that it can stand anywhere. And such education programs have to be monitored, maintained, and offered quarterly or annually to ensure that people are refreshed, and their refresher courses if needed, to make sure that people are aware of any changes. The answering questions to who, what, why, how will help to ensure that individuals have a solid understanding of organizational practices and measures that maintain individual best practices. It's also important that in education, we have to make sure that updates is part of it. We know sometimes the various tools we have, electronic records we have, sometimes get updated. It's very crucial that those updates are spread across all users. That way they know when there's a change to a particular, maybe an icon or maybe a template. Everybody is aware and they use the right thing at the right time. Still on the recommendations, the creation of documentation guidelines, policies, and procedures surrounding the use of medical records and related tools for capturing information, with emphasis on validating and documentation validating any documentation copied and pasted is very important. We have to emphasize this across the board, that if the documentation or any part of the documentation is copied and pasted, it has to be verified and validated before attested to, because once it's attested to, it's taken as the record documented by the physician or provider. deploying a clinical documentation improvement program that will aid in identifying errors in documentation and getting such errors corrected is also important. We do see a robust growth in clinical documentation improvement programs, and it really, as CDS says, we play a vital role in helping ensure that the integrity of the medical record is maintained, because if we do notice discrepancies or unreliable documentation, we're able to bring this forward to the attention of the physician and it gets corrected in real time. So the role of clinical documentation improvement is very crucial also in ensuring that medical records have integrity. In addition, programs need to clearly the organization's disciplinary and termination policies governing falsification of records, security, and access breaches or violation. This is very important because all users of the medical record need to understand the consequences or the actions that would lead to falsification of records, and they need to understand the consequences of falsifying records, either intentionally or unintentionally, and the violations involved with all this. So if we do have programs that educate all users on these various policies, violations, consequences, it will go a long way in addressing the integrity of the medical record. And we have various oversight agencies and various acts that are out there. We have the Federal False Claims Act, we have HIPAA, we have the Deficit Reduction Act of 2005, we have CMS, we have the Joint Commission, all this, and of course the medical staff bylaws of the organization play a role in addressing the consequences or actions that will be carried out if there's a violation or falsification of records or misuse of medical records. These all go to ensure the integrity of the medical record. In selecting an EHR that would help with maintaining the integrity, of course, all EHRs have their security and files that help prevent any misuse of data or transmission of data. EHR with the following can help in ensuring that the integrity of the medical record is maintained. Like when you have the user authentication, logging up all activity, maybe if you're not using the system, is inactive for like 30 seconds, it logs off all activity, the ability to verify validity of information on entry when possible, checking for duplication and conflicts, control and limit automatic creation of information. So if we do have EHR systems that able to control and limit automatic creation of information, that also helps to prevent any redundancy and any misinformation. And also an EHR system that is able to monitor corrections and additions to the medical record is also it's a winner anytime, because you'll be able to track and see where there are problems and provide education as needed. Electronic health records has brought a lot of opportunities and innovations that aid improved patient care and provides an avenue for efficient practice management. So it does do a lot of good. The only thing that we have, we're talking about is how to protect the integrity of the electronic medical record and identifying the risks that are involved with not properly utilizing the tools available in the EHR, and the downsides of or the consequences of not utilizing the tools, and how we could prevent these things or mitigate the risk associated with misusing the tool. So the goal is to make sure that, one, the medical record is protected, of course, by security, and that we want to make sure that when we have tools that will help the providers provide better quality of care without misusing them, of course. So, like we said, for example, we would like to make sure that our autofill template, is the physicians go through it, remove irrelevant data. In copying and pasting, also, we want to make sure that they are looking through the documentation when they copy and paste, be sure that they are they are removing things that um, do not pertain to the current admission of the patient. And of course, trying to prevent copying and paste lab results and things that, or even medication for that matter, things like that. We don't want that to be brought forward. So while the EHR is a wonderful tool, it helps across the board. We also need to be able to educate our providers to use the tool more efficiently. And to end this, we'll say, taking a quote from the Health Information Management Technology and Applied Approach book, data integrity means that the data should be complete, accurate, consistent, and up to date. Ensuring the integrity of healthcare data is important because providers use them in making decisions about patient care. We cannot overemphasize the power that is in our hands to take care of our patients. And we want to be able to provide excellent care, excellent, of course, and safe care to our patients to make sure that the tools that are provided to us are used efficiently in the